I always tell my patients that with the birth control pills, you don't have to have a period. You can take these things continuously so you never have that breakthrough bleeding. It's not a true period. It's just that your uterus kind of sheds the lining.
Mm-hmm.
And I love this little history tidbit is that the reason birth control pills have that week or the 5 days of placebo or the sugar pills is to satisfy the church back when it was first on the market because it was natural.
I'm really looking forward to talking to you, Dr. Mona Guo. I said that right. Yes.
It was close.
It was close. Okay. Please correct me. I'm just going to call you Mona. If that's okay.
That's totally fine.
We've spoken before, and you spoke at length with my partner, Christina, at an event in May. And she was like, just really excited to be able for me to do this with you. Obviously, gynecologic oncology is the Lynne Cohen Foundation's sweet spot. Mm-hmm. That is where I want to say like this foundation was born and raised. You're at USC Norris Cancer Center, which is also where this foundation is born and raised. As you probably know, from 1993 to 1998, that's where my mother was treated for ovarian cancer. And we have had a lab there and we do tons of work there. And of course, have a clinic for women who are at increased risk for breast ovarian cancer. But what I would love to get into with you today is sort of start with who you are and your background and why you picked this specialty, because I think that's a really interesting path. And there are usually some kind of interesting reasons why you might have chosen this specialty. And then I want to talk about the state of ovarian cancer and where we're going in the future.
Yeah.
So thank you so much for being here.
Thank you for inviting me. I am honored. I mean, looking back at all of the previous guests you've had on here, I'm like, little old me, why should I don't think I should be here.
I don't think that's accurate. Thank you for trekking all the way out here. We're doing this one in person in Santa Monica, which is kind of the end of the Western, United States. So if you're not in this hood, it's definitely a far drive. So thank you.
Beautiful space.
It is, and it'll come out really well. But tell me how you ended up in this field, how you ended up as a researcher and a doctor who sees patients.
Yeah.
Like, it's an incredible balance that I believe heavily in. So just give us a little pathway.
It was not in the books initially.
Okay.
Gyn onc was kind of as last of a thing that I could have possibly thought to do. I went into medical school wanting to do child psych, actually, because I did a lot of work with children in college. I worked in Boston's Chinatown, saw myself and some of the children there, and I was really interested in child development. So that's kind of where I went into medical school. OBGYN was also not something I was thinking of doing. Just thinking about obstetrics, thinking about surgery, having not had any exposure to those things before was not interesting to me. But when I did my rotation, OBGYN was about women, right? It's about taking care of the people that take care of people.
Oh my God, I love that. Will you say it one more time?
Taking care of the people that take care of people.
Yes.
Yeah. And that just struck me so much, is that I'm going into a field, medicine, where I want to help people and I want to be able to care and make things better. And here are the women who were coming to see us at that time I was in Connecticut, and I was in a hospital that is one of, I believe, the highest disparities in wealth. It was Hartford, Connecticut. And seeing women who just put things off for a long time in order to take care of kids, take care of husbands, families,
everyone
parents,
but themselves.
Everyone except themselves, yeah. And it just was so meaningful to be able to be there for them. So I pivoted to OBGYN. I loved everything that was in the specialty, taking care of, from babies to young women to mothers, and then to the whole spectrum of care. And I was going through residency. GYN oncology, so gynecologic oncology, was really the one area where I truly felt I was being a real doctor, a full scope practicing doctor. As you know, we do see patients for chemotherapy as well as surgery. So we're able to follow someone through their entire spectrum of their care. But it's not just about treating something. It is also so much about prevention, which is all of OBGYN as well. We are a specialty, but we're also primary care. And so much of primary care is preventing the disease before it gets there.
Yes.
And GYN-onc was just a perfect amalgamation of all of my interests. I loved being in the operating room. Being able to fix things is really satisfying. Being able to take out large tumors and make someone feel immediately better, but also being able to talk to a young woman through her options, whether it is from doing things that are fertility sparing, or if they have higher risk family history or genetic reasons to need to do surgeries that really define ourselves as women. And being able to walk someone through that brought me a lot of joy as well. And doing surgery that was risk reducing also was just as satisfying as doing surgery to take out cancer, because now you've changed, hopefully, someone's trajectory of their life. So that's, a roundabout way of saying how I got to where I got.
So let me pick out a tiny piece of that, which is we're going to zig and zag.
Yes.
But I don't want to let this go. Will you talk to me about risk-reducing surgery? Because I know about it and I've had risk-reducing surgery, but I don't think very many people do when thinking about gynecologic oncology and gynecologic cancers. So will you dive into that and what that means? Surgery for what? Why? I think that would be really interesting to hear from you about.
Yeah. When I took this job at USC, one of the first things I told Dr. Linda Roman, who you know well, and our division director, is that I wanted to be in this clinic. And there was an opening for it, so it was perfect. But I'll start at ovarian cancer. But we can talk about risk-reducing surgery, I think, in other areas as well. So we all have a baseline risk for cancer and various types of cancer. And if you take out all your organs, you're not going to develop any cancer anywhere, but you're also not going to be, living the best life.
Fully functional human being. Yeah.
But for some people, they have a higher risk of developing certain cancers, sometimes because of genes that we do know of, oftentimes because of genes that we do not know of. And we learn about those risks from family history and from other diseases that a patient might have. For ovarian cancer, most commonly, BRCA1 and BRCA2 are what we hear about. There are a bunch of other genes also that are in the high-risk ovarian as well as ovarian breast cancer group. But for patients with BRCA1 or any of these high-risk ovarian cancer genes, one of the best things that they could do to decrease their risk or reduce their risk of developing ovarian cancer is to take out those ovaries and take out those fallopian tubes. We are in a time where we have so much good data now and emerging data about the benefit of taking out fallopian tubes ahead of time and leaving the ovaries in, because
which is what I did at 40.
Yeah.
It's almost 10 years ago. Yeah.
Cannot tell.
But you can.
No, but so ovaries, if you take out your ovaries, you go straight into menopause.
Correct.
And we do have good hormone replacement options from medicines to patches, but it's not the same as having your own hormones inside. And the recommendation for risk-reducing surgery for, say, BRCA1 is to do it by age 35 to 40. So when someone is still in the prime of their reproductive years, but also young and in the prime of their careers and being a mother, a wife, a person, a functioning person. So there's some good data that now taking out your fallopian tube beforehand will be able to reduce that risk by probably up to 70, 80, potentially even 90% because of this thought that ovarian cancer actually comes from the fallopian tubes.
Yes.
So taking out those tubes reduces your risk of ovarian cancer. Taking out your ovaries will also reduce your risk of ovarian cancer.
And taking out your fallopian tubes, respective of surgeries, is like no big deal. I mean, it was a nothing. I would even call it a surgery. I would call it a procedure. It was in and out, and it was really not. Obviously, I didn't have anything happen. That could have the long list of
side effects
this and this.
Possibly.
Yes, side effects or things that could happen during surgery. But it was probably the easiest procedure I would ever have. And Dr. Roman was the one who I consulted with, and she was like, "Have your fallopian tubes out. You've had 3 kids. You're done having children. Let's not touch your ovaries. You're still 40. Let's keep them in there as long as possible." And I'm not BRCA positive, but she treats me and sees me as someone who carries a genetic mutation just because my mom was so young when she was diagnosed. And at the time, I don't even think now that new way of looking at ovarian cancer is not well known. It's not like a common understanding that majority, you correct me if I'm wrong, please, ovarian cancers start in our fallopian tubes.
In medical school, I think it was just emerging.
Yeah.
And it was, a little sentence in the books. But now
it's like a game changer.
Yeah. I think just this past year or this year, our like major medical societies are putting out publications saying that they recommend women, normal risk women. So we all have about a 1% chance of developing ovarian cancer, should get their fallopian tubes out if you're going through a surgery for something else. So say you need your gallbladder out, maybe just take those tubes out at the same time. Or if you wanted to get your tubes tied after completing your family building,
take them out
take
instead.
the entire tubes out. Yeah, exactly. It's still a major procedure in the sense that you're under anesthesia.
Yes.
But yeah, it takes, less than 30 minutes to do. And
recovery
is
that day.
Exactly. For our female organs, you have your ovaries and then your uterus. Certain genetic conditions, you can also have increased risk of uterine cancer. So risk reduction for that would be doing a hysterectomy or taking out the uterus. And the uterus and the ovaries are separate. So you could do one or the other and do stage surgeries. So for some of the high risk uterine cancer genes, which also does include BRCA1 as well, and it's a discussion with your doctor about whether you should take out your uterus first and then go back and take out the ovaries, take them all out together. It could be staged procedures. But yes, taking out the uterus would then reduce that risk of uterine cancer. For GYN cancers, those are really the only surgeries that we could do. There are some other high-risk genetic conditions that are associated with cervical cancer, which unfortunately you could then actually, I take that back, you can take out your uterus as well, because then your cervix would come out with that too.
Okay. What else in this sort of preventive umbrella of gynecologic cancers and even just let's say women's cancers, do you do research on? Are you thinking about? Are you working with? Are you talking to patients about? Talking to your colleagues about? What else is sort of out there in this world of prevention and preventive care that most women don't know about?
From a cancer standpoint, birth control pills are fantastic. And I talk about that with every patient who comes in who has honestly, if they don't even have an elevated risk, is that when we're considering our choice of contraceptives, birth control, so the birth control pills that you take, the way that they work is that they stop you from ovulating. And by stopping that ovulation, you're stopping the small damages that come to the fallopian tubes and the ovaries every time, which is how cancer develops, is that when an egg, say, spits out of the ovary, it causes local inflammation and local damage to the fallopian tube and the ovary, and then your body has to come back in and repair.
I did not know that.
Yeah.
I've known that being on the birth control pill for a pretty long period of time or any period of time, I would like to hear more about that, reduces your chances and because you don't ovulate. But I didn't know that last piece. That's fascinating.
Yeah.
But our body does, it's crazy.
It is.
And it doesn't repair itself.
So it does repair, but every time you're continuing to repair, which is why skin cancer is the most common, because your skin is always getting hit by UV rays and other things.
Okay.
But for certain genes like BRCA, the BRCA gene helps with DNA repair. And so if you have problems with DNA repair, now every time you're repairing something, you have a chance of it going wrong. So by taking birth control pills, and also the progesterone IUD can also sometimes decrease ovarian cancer as well, because it can decrease ovulation. So you stop that ovulation, you stop the damage, and you decrease the times that can happen.
Ideally, what age would you try to get to women and suggest this preventive care path?
Anytime.
Okay.
Really any time. It is, like you mentioned, how long you need to take it for. The data we have is for 5 years.
Okay.
But really it's, there's nothing special about 5 years.
5 total years or 5 years in a row?
At 5 years total of someone having had taken birth control pills, that they can reduce their risk of ovarian cancer by about 60%.
Wow. Okay.
So you take it longer, you take it shorter. There's not a magic thing about 5, but that's where the data is.
Okay.
So when someone is deciding what type of contraception that they would want, and it's not just for contraception, it's also for heavy periods, it's for painful periods. Endometriosis is getting more screen time and airtime now, which is good. All of these conditions can be treated with controlling our hormone balance.
Okay.
So some patients would want the birth control pill. Some patients would want an IUD. There's also different formulations of birth control. So if you've had a bad experience with in the past, doesn't mean that you're going to have a bad experience again. So you can try some other ones and work with your doctor.
Okay.
I always tell my patients that with the birth control pills, you don't have to have a period either. You can take these things continuously so you never have that breakthrough bleeding. It's not a true period. It's just that your uterus kind of sheds the lining.
Mm-hmm.
And I love this little history tidbit is that the reason birth control pills have that week or the 5 days of placebo or the sugar pills is to satisfy the church back when it was first on the market because it was
That is
natural.
so unbelievable. And no one ever told me that until I was long off the pill and hadn't kids and had no fallopian tubes, that I could have just taken it. And I remember, this is so nutty, but I remember the week of my wedding. And I was 25 years old and I was like, is it going to line up when I have my period on?
Yeah.
I had been on birth control for 10 years at that point.
Yeah.
Because my gynecologist, when my mom was diagnosed, she was like, my sisters, you're going on birth control now. Whether you're sexually active or not, didn't matter. And no one had said to me, just take them all the time.
Yes.
That is like, I do know that now, but I did not know the reason behind it, but it makes complete sense.
Right.
Being a woman. Oh my God. So we're like normal.
Yeah.
That is unbelievable.
Exactly.
Okay.
And then from screening, right, cervical cancer, HPV, getting the vaccine is approved now for up to age 46.
Wow.
So even if you hadn't gotten them before, or if you had back in, I think before 2006, it was the 4-valent. So it prevents 4 types, or it covered 4 types of viruses of the HPV virus. And now it's 9. Still working on the data for this, but getting it again is not harmful. And then you protect yourself against more. And then doing your pap smears according to whatever risk factor you are. So it's every 3 to 5 years. Some people might need it annually for certain reasons to prevent cervical cancer. And then a lot of, I think, our cancer prevention is really just knowledge and understanding. We tend to normalize things. Being women, we normalize things. The world normalizes things for you as well, saying that certain symptoms are just part of menopause or part of perimenopause or just your hormones. And if something doesn't feel right or continues to not feel right, that you advocate for yourself and go get that sought out and checked up. And if your doctor's not listening to you, find someone else to talk to.
You're like speaking my language. My kids make fun of me because my line is, "Know you're normal."
Yeah.
And also, I think as women, it's really important to understand that our normal changes.
Yes.
And so what felt normal at 15 is not going to feel normal at 25, 35, 45, 55, 65. But it's important to always check in with yourself and understand what is normal for me now in this period of my life. And when you're outside of it, yes, advocate for yourself. We are so bad at that as a gender. I think maybe a little better, but certainly not where we should be. And it's, to me, probably the most important lesson that we can learn, starting at a very young age for all things.
Yeah.
But certainly our health and wellness.
Yeah, exactly. And then the one thing I missed about prevention here is, or risk reduction, is the IUD also helps prevent your risk of uterine cancer specifically.
Why is that?
So the way that the IUD works is it's in the uterus, and it puts out local progesterone, so one of the female hormones. By doing that, it prevents the endometrium, which is the lining of the uterus, from overgrowing. And so uterine cancer most uterine cancer is endometrial cancer, and it's cancer of that lining. So by stopping that continued growth and shedding, so again, similarly, you're not having continued inflammation or continued shedding of that lining there. The term you'll hear is unopposed estrogen, which is where our hormones are going into the uterus to try to increase that lining. The IUD stops that lining from forming. And when lining overgrows is where cancer comes.
Okay.
There's certain genetic conditions that can increase your risk of having that uterus cancer, but also, unfortunately, things that we see a lot of in our modern day. So whether it's estrogen exposure from, unfortunately, being overweight or obese, if you are given estrogen for hormone replacement and not giving progesterone to help balance that, that increases your risk of cancer as well. And a lot of things that we don't know right now, which is whether some of the products and commonly used things around us in the environment are also causing that or not.
I feel like the hormone replacement therapy and HRT is I'm almost 50. And so I have to talk about it all the time. But I actually think that the idea of balancing your estrogen and progesterone levels it's almost assumed, it's understood, but I don't think that it really is. And I think in the just the lay community, but also doctors prescribing. And so I think, a lot of doctors, and I've met a few and clearly not talked to, they're not my doctor, but who've been like, oh, you're definitely from your, was very clinical, listening to me, hearing my symptoms, what I'm going through. Like, you don't have enough progesterone, and kicking that up without talking about the other, hormones I'm producing or not producing. So will you talk a little bit about that? Just this importance of balance?
Yeah.
And really why?
And what you're saying, that we are not taught this.
Yeah.
We aren't. It's not taught in medical school. We really didn't learn much about it in residency as an OBGYN. How to replace hormones and what it means when hormones are unbalanced. And I feel like in my practice now, I'm really starting to see that. Whereas before it was just, we learned that when you take out your ovaries, you replace estrogen based off of symptoms. And that if someone didn't have a uterus, you didn't need to replace progesterone, because the point of progesterone, as we're taught, is only to counteract estrogen. But I think now, as I see patients, especially the younger ones who end up getting their ovaries out for cancer, for other reasons, and estrogen is not enough. It confused me. Like, we're taught that all we had to do was to give you this patch and it should be fine. And it can keep on going up in the estrogen, and yet they're still not sleeping well. They still have other issues with mood, with just how they feel in their body. And giving back, I think, progesterone, sometimes giving back some testosterone. Those are all components that I personally I'm not trained on doing, and I don't know how to do well. So that's where I start to ask my colleagues who are more skilled and more versed in hormone management to really work with me, with these patients, and work with the patients directly as well. Because it isn't, we're not by the book.
It's a bit of art, right? It's an art as much as it's science. And it's individual.
Exactly.
And I think it's also clinical. So there's not like a test. You could test hormones, but it's like a blip in time.
Exactly. Right. That is so important. And people are coming asking for their hormones to be tested. But if we don't know what we're testing them for, and also we just don't know what to do with the information that we have. If depending on your medicines that you're on, that can affect your hormone levels. So yes, it is. It's an active conversation, and it's a back and forth about adjusting, and it is very much an art.
And I think I've said this a few times, and I've really believe it. I'd love to know how you feel about it. Seeing as you went through OBGYN, your training, I think OB and GYN should be two separate fields. I think seeing personally, maybe not, let's not make it that dramatic. I think that the person you see as your gynecologist after 40 is not necessarily the person that you should be seeing who delivered your babies in your 20s or early 30s. I think there is an entire specialty that is surrounding, younger women, generally speaking, of course, who are fertile and having babies, and seeing them through, pre that time, and then while they're pregnant and post-pregnancy, and, helping them, whether it's in your practice or not, to, talk about the baby and all that stuff, versus the doctor, the gynecologist who you're seeing in your 40s, 50s, 60s, 70s, who potentially has really done more research that obviously wasn't taught in medical school about what the woman's body is like and what we're going through. Because it's black and white. I mean, it's so different. I don't know. Do you think I'm nuts by thinking that, or even saying it out loud?
You have your finger on the pulse of this specialty right now, honestly.
Okay. Yay! I know. I'm actually doing my job.
That is what I mean. From a training standpoint, yes, that whether we should be splitting OB and GYN has been talked about in the past probably 5 to 10 years from a training perspective.
Yes,
because it's so much to also learn in 4 years.
Yes.
And you end up not learning either of them as well as you could be. And usually it's gynecology that takes the backseat because babies need to be born.
And they will be every single day. Yes.
And then so you come out of residency training really good at OB, but really I feel like where we're missing out on is in the GYN.
Yeah.
And that just continues and perpetuates in our practice and our training. So yes, you are saying something that probably I'm hoping that in the next, decade or so, that we're going to start seeing that change.
Yeah.
And I think the reason OBGYN is a specialty is the reason why GYN oncology does everything too, is that women's health just gets lumped into this bucket of, well, you're a woman, you have your female organ, so you're going to be just taken care of by this one person.
And I'm not a big against the man, go against the man. Yeah. I'm not sitting here to do that. But I mean, back to what you're saying, the pill had placebo for, 5 or 7 days. But it's also when we are as women sort of treated as our most important selves is in that OB stage of our life, which is, was great for me in my 20s. But I feel it and I see it. And I see it from just being a person and a woman and also being someone with a toe in the medical community that it's not a backseat, but it's certainly it's not sitting in the passenger seat with the OB field.
No, it's very true.
Yeah.
And I mean, they are doing some amazing things in OB and in embryology and OB and maternal fetal medicine. So taking care of a mom through some really high risk pregnancies and helping to get women pregnant and through a pregnancy and with very complicated medical care. But that's a very different medicine.
Yeah. And oncofertility. I mean, it is. It's a really,
Yeah.
So taking a step sideways, from your perspective, which is young and fresh and new and in the trenches at one of the most prestigious cancer institutions in our country, if you had to give a talk on the state of gynecologic cancers and also specifically the state of ovarian cancer today at the beginning of first quarter 2026, what would you say? And you could be very general or very specific.
The main thing is targeted treatment and targeted therapies. I mean, all cancers, but in GYN right now, it's really exciting with all of the targeted stuff that's coming out. And this is where we're looking at mutations in the ovarian cancer or in the cancer cells and finding specific proteins that we can take chemotherapy to attack those proteins directly. And so how chemotherapy works is that it's like throwing a bomb on all of the cells. And the chemo attacks the cells that divide most rapidly, which tends to be cancer cells, but also tends to be your hair cells, your skin cells, stomach lining cells. So it causes all those side effects. But if we can find specific targets that are on cancer cells that are not on normal cells, then we can get those chemotherapy just in those cancer cells.
Okay, that's amazing.
So in the past 2 years, 3 years now, ovarian cancer has had 2 new treatments that have come out. One of them actually has had survival benefit, which hasn't really been seen in ovarian cancer chemotherapies in a while. But one of the other treatments is their broad name for these are ADCs or antibody drug conjugates, which means it's an antibody specifically for an antigen that's on the cancer cell. And then the drug goes directly into that cancer cell.
Okay.
Ovarian cancer is one of the first cancers to have an ADC for it. I don't know if we can say the names of these chemotherapies, but this chemotherapy we're giving more options for treatment after our standard chemotherapies have been exhausted.
Okay.
But also maybe taking these targeted therapies and moving them earlier. Yeah. So not just throwing the carbotaxol is what you'll hear for ovarian cancer, for GYN cancers. But maybe we don't need to start with carbotaxol. Maybe we can throw in some of these targeted agents earlier so that we have patients undergo treatment but still have better quality of life.
Yeah.
And then be stronger for whatever happens afterwards. So yes, targeted therapy, personalized medicine, I think is really exciting and will change how we treat cancer and how we approach cancer treatment.
It almost feels like a more holistic way of treating the cancer patient because this is how I see it. It's very exciting. You're coming at it from the very medical scientific point of view where you're lasering in on what you need to do. But it sounds like it also maybe as an afterthought, but it was conceived in a way that it is also helping a woman get through this horrendous time. And historically, the treatment for ovarian cancer is just incredibly brutal. And my guess is because it's often caught late, and that's just the treatments that have been on the table for decades. So being able for a woman, and those two things that you said really blew me away. One is to, feel better throughout the treatment, but also to be stronger to get through the whole series, whatever may come.
Yeah.
That to me, in particular, with ovarian cancer has been so difficult to watch that it's not even often the ovarian cancer that ends up killing you. It's the inability to fight off the things that are going to come because of the treatment.
Exactly. And I think to jump on that and continue on that, the surgeries for ovarian cancer are also very brutal.
Yes.
There are some of the biggest surgeries that we do. And from a surgical standpoint, they can be very complicated, but also very specific. You have to work in very small areas and around some very, very sensitive organs. And also in the past, decade or so, doing less is starting to become more. We're starting to do less more often. And that started really in endometrial cancer by using sentinel lymph node biopsies in endometrial cancer, which means instead of taking out all the lymph nodes, you're only taking out the few that are the first ones to drain the organ. And so for ovarian cancer, there's research now looking into whether we can do similar technology where you inject around the ovaries to see which lymph nodes you need to take out. So you don't end up taking out all of them and having the long surgeries, but also the side effects afterwards of lymphedema and lymphoceles, like fluid being collected in different places. But also having not just sentinel lymph nodes, but whether we can inject inside the blood a colored imaging that can find those ovarian cancer cells and tell us what do we actually need to take out. Because a lot of these surgeries are now done on the interval side, which means you get chemotherapy first and then you end up doing surgery. And sometimes the chemotherapy works well and you end up with this tissue that you don't know if is actually ovarian cancer active or is it just already scar tissue that's left behind. And maybe we can use these certain imaging modalities that can help us decide maybe we can do less and be less aggressive with certain surgeries, get someone off the table faster so that they can get back on their chemotherapy and not have to stay, in the hospital for days and days on end and do less so that with the same outcome ultimately.
That's amazing. That would be really incredible. My mom had a lot of lymphedema.
Lymphedema.
And I didn't know why. And now I know why. I hadn't, probably because all of her lymph nodes were gone.
Yeah.
And it was, of all the 5 years of treatment and side effects and everything she went through, that was the worst for her.
Yeah.
Physically and mentally and emotionally. And I remember thinking, it's not that big of a deal that your legs are so swollen and your abdomen so swollen. But for her, it was a physical sign of her body. I think the way she understood it, and I'll never know for sure, but I think the way she saw it was like my body's not responding positively. And that must have been so emotionally awful for her. And as a caregiver and as a loved one, I don't think we think about those things as much because we're like, whatever it takes.
Yeah. The cancer is gone.
The cancer's
that's
gone.
What's important.
Who cares about these things? But I do think, and her cancer wasn't even gone, but I think that it is so much more impactful than we give it credit.
Yeah.
Yeah.
And as our therapies are getting better and as we have more lines of therapy, which means that patients are living longer, I think this turn towards focusing more on that, what it means to be a survivor, but not really even a survivor, but someone who is living with cancer for longer. And how do we support someone through that? Because you're right, like we tend to think that as long as we are attacking the cancer and the cancer is being kept at bay, we should keep doing everything to do that. And that's success.
Yeah.
But that's not success if you're not going to be able to live your life. I'm going to do a little bit of a plug here for what I want to be doing. And what we're hoping to bring to USC soon is to start up an integrative program there. So using integrative medicine techniques to really help get a patient through that treatment.
I love that.
And through what it means to be done with treatment and to be a survivor afterwards. Because that time will hopefully be longer and longer.
Yeah.
But what's the point of, going through treatment for your cancer if you can't come out the other side, still being able to be you.
To live. And I think also, I interviewed a while ago this incredible woman who is a cancer survivor. Her business now is working with women who, from beginning to end, meaning beginning of their treatment, diagnosis, treatment, to after they're done and they're alive, then what? And how do then you live the rest of your life, this new normal,
Yep.
this new, world. Your bodies might have changed, your insides, outs, everything. And it is really interesting. And I think that, it's this really holistic, integrative way of looking at it, I think is amazing.
Yeah.
I hope that it does.
I hope so
I hope
too.
you do it, Mona. So tell me quickly about, you said a while ago that you were excited to work at the preventive care clinic that we have at USC in LA County. And so why? Why was that exciting for you? What is it like being in that clinic? And why is it, I assume rewarding? And why is it continue to be a part of what you do?
Mm-hmm. I mean, you brought up LA County there at LA General now.
Yeah.
I did residency in a place that also had a county hospital. And that was really important to me, looking for where I was going to go next, was to have that ability to work in both sides of medical care. Because it's very different to work at USC Norris and then to walk 10 minutes and then go to LA General and work.
Yeah.
We can talk an entire hour just about the differences
Which
there.
we might. Take two.
Yeah, exactly. I really wanted to work in Lynne Cohen specifically because what was important to me was helping patients make those decisions for what to do next in regards to their care that made sense for them individually, for where they were in their lives, with what they wanted with their families, and where they saw themselves in 5-10 years, because that's going to be different for everyone.
Yeah.
And those conversations, being able to have those conversations is, I'm honored to be in the room, to be able to share the conversations with our patients. But guiding someone through making those decisions really made me feel like I was working at the top of my medical career, basically.
Yeah.
Deciding to do something to prevent something in the future, it's a very abstract idea.
Yes, it's very difficult to get healthy women in to talk about what might make them sick.
Exactly. Yeah. You're coming in here, everything's going well. For a bunch of these patients, they are they're just finished with college, or they're at the peak of their careers. They're excited with life. To take time off, potentially do surgery, or to be coming and seeing me every 6 months, sometimes every 3 months, it's a big deal. I feel like being able to be there for them and feel like they want to come back and continue seeing me and helping, and for me to be able to guide them through this reminds me why I do what I do.
Yeah.
And then from the flip side, at LA General, patients have very different struggles. Right? The patients that are coming to see us at LA General often are taking 3 or 4 buses to get there. They need to balance their childcare. Everyone does, but sometimes they bring their kids with them. They have to bring their parents with them sometimes. And trying to balance over there is, how am I going to take time off of work that's feeding my family in order to do something doesn't affect me right now, right? Why should I do something right now that's going to cause me immediate difficulty with my life when I'm well? And walking someone through those situations, but also connecting patients with other patients who have gone through something similar.
Yeah.
And then considering what things could be like in the future if they were to develop cancer, or were to, God forbid, have something happen where they're now unable to work or unable to care for their families.
Yeah.
Having those conversations are very different, but again, really, really rewarding for me too on that side. And then working on both sides, it really brings to focus for me that, when a patient can't see themselves in the other patients that are around them, it's really hard to impress the importance of something when what you hear and see out in the world doesn't reflect who you are.
Yeah. It's so abstract.
Yeah, exactly. Lynne Cohen does a great job about having these resources, right? You do the podcast, you have the run, and you have resources on the internet for patients. For our patients who don't have high-risk ovarian cancer, or aren't in this patient population that's captured by a preventative clinic like this, they feel really lost.
Yeah.
And it's much easier to close an eye and ignore something than it is to take that time to do something about it.
Yeah. Ignorance is bliss for most people.
It is. And it is bliss for a long time until it hits you in the face.
Yeah.
But being able to work on both sides and being able to work on access, not just to getting preventative care, but access and getting someone to be seen by the right people is a big part of what drives what I do too.
Well, I could talk to you for a very long time. And you've opened doors to many other questions in my head, but I'm not going to keep you. And this was really, really special and really enlightening. And from, your whole trajectory, and what makes me really, I feel very excited about the future when I hear it from you. But you're in the know. I think I tend to think things will be better, or things are getting great, or discoveries are happening. But until you really hear it from someone who's like you, you're seeing patients, you're talking to them, you're with them, from the beginning to the end. And you're also in the research world. And so I think that the marriage of those two, or three or four, whatever you want to say, means you're speaking from a place of know. KNOW. You're speaking from a place where you know what's going on. And you also know how it's affecting the patients and the patient landscape right now, which for many, many years was very dire. And I think it is not as dire. And I think it sounds like there's some really incredible breakthroughs that have happened. And I know on the ovarian cancer side, everyone's like, when will there be a blood test? Yes. And I think a long time ago for me, many years ago, I stopped sort of saying that and thinking that and asking that, and instead tried to focus on what are the breakthroughs that might not be that.
Yep.
And it sounds like that your world is having them. Yeah. And that's incredibly positive for the rest of us and for all women. So most importantly, thank you. Thank you for choosing this as your path. You're obviously brilliant and kind and empathetic, and very similar to Dr. Linda Roman, who I love and adore. And I always describe her as someone who's, brilliant and research-minded and focused, but amazing with patients. Yes. And clearly you are too. And that is an unusual mix in this world. It really is. And I think that we women are really grateful that you are here and you're doing what you do. And thank you for taking time out 2 months postpartum to talk to me and to let everyone know who's listening that things are moving forward.
Yeah. I mean, thank you. I have to thank my mom for watching my 2-month-old right now, right? That community of women.
Yes.
But I mean, thank you for having this, but also having the Lynne Cohen Clinic and supporting us in what we do. Because we can say about all of these exciting things that are happening, but without support from people like you, we can't make those breakthroughs, and we can't be taking time out from clinical care to be able to do research and to do other things that will hopefully advance and get rid of cancer.
We hope so. We hope so. And even if it's not getting rid of cancer, it's understanding it better, treating it better, and giving people better outcomes.
Yeah.
And so I think we're doing that. And that's why I keep doing this. And it's really about my mom's legacy and knowing that really good work is being done in her name. So thank you for being part of that.
No, thanks for having me here.